what's going to be a really fun night of FitFoot U. I'm Dr. Ben Pearl. I'm a podiatrist for those of you that don't already know me. And I've had the pleasure of working with Adam from the club, and then also working with one of my mentors, Aaron, to try to coordinate with some of the podiatry students to jump on this call. And we're going to be lucky enough to have two great clinicians and physicians, Dr. David Armstrong. He's out of now Los Angeles. He's a professor there of surgery. And then we're going to have Dr. Bijan Najafi, who is another clinical researcher. They collaborate on a number of studies, and they're going to review a few. And one of the things that I wanted to lead with which the title is of why research is particularly relevant currently, is that we, with the pandemic, have been in a state of information and disinformation. And I think now more than ever, we have to really pay particular scrutiny to the level of information that we're hearing, the sourcing, the number of repeated studies, and the context. I think that a lot of the information that we're hearing now is out of context. Now, in the news, and I think appropriately for this topic being presented tonight, is that we just heard that, hey, David, and this man needs no introduction, as David Letterman would say. But what I was going to do, David, before I have you give some eloquent words, is just set the context of what I thought was just unbelievable, which is that we have had 3 or 4 major drug companies, and people are just, the sky is falling with 6, which is, it's never good to have deaths, 6 in a million, which is less than being on the LA freeway and taking your car out to drop your daughter off. You know, I mean, sadly, that's how it is. I mentioned, and you can share some of your credentialing in a minute. David has been a real maverick in both podiatry and crossover to the MD allopathic, holds both degrees, which I just recently relearned that. When I was a student, just to give a little bit of context, I did some very, how shall I say, hastily put together research as sort of a maraschino cherry on a Sunday of some work I was doing, looking at the effect that sports can have for people that have physical disabilities psychologically. And I had done some field work. I had done some stuff at NYU Medical Center and written papers on the influencing of things, even as we look at color as an influence of our perception. And one of the interesting studies that I read was about how people will remember things they are more familiar and be more comfortable with what they're more familiar. And they did an example of playing cards where if the ace, let's say the 3 of spades was turned to a red 3 of spades, you would not remember it as much as if it was a black 3 of spades. So they had all these different things that I read about sort of psychometrics of how we perceive and how we process information. And the final thing that I did as sort of a wrap up was I said, let's get some college students to look at people with physical disabilities doing sports, and also that same actor doing desk work. Well, we got a group of students, and I wanted to get more, but like a lot of things, it's hard to organize. And the School of Health, Physical Education and Recreation at Indiana University got me 18 or so students. And I said, well, we don't have a large number. Let's show them the film. And we showed the film of the desk work. And then we showed the film of the same actor doing basketball with his physical disability, left from a wheelchair. And then I surveyed the students. I said, okay, would you feel comfortable having a beer with this person? Would you feel comfortable inviting him to a party? Would you feel comfortable hiring him for a job? Well, naturally, as you might have guessed, people felt more comfortable with the second scenario where this person was doing sports. They just felt like more capable, more affable, etc. Well, the interesting part about this hastily conceived study was that I didn't get to matriculate in the spring. Does anybody, and I'll let my assistants for many of the students give anybody an answer to say what was the tragic flaw with this hastily conceived maraschino cherry of a study? Anybody want to raise their hand, and I can let the proctors select a student? Anybody want to jump in? Julianne, say what was wrong with the study. Or are you popping in? Anybody have an idea that they want to share about it? David, can you tell me what was wrong with that study? I don't know if you caught the whole gist of it. I showed a group of students, a person with physical disability doing desk work, and then that same person showed the group, again, the same group, the person doing sports, and then had them rate different things that they would feel comfortable with.
Well, Ben Pearl, I was actually just admiring it. I was trying to say, it seemed like a kind of an elegant idea, actually, to try to conceive, because, I think a lot of times we tend to feel comfortable with people that look like us, right? And that's, and I think people make decisions with these implicit underlying biases, and maybe if we or somebody, played sports, or then maybe we would feel more comfortable with someone else, kind of a backslapping kind of situation. Or if we saw someone maybe that was disabled, then we might have some kind of ableist sort of perception about that woman or man. And that happens all the time. I mean, we always ascribe, and we do it. There are these underlying. I don't need to tell everyone here about that, but I thought it was enough.
I mean, that's one of the things we do with podiatry, is to try to keep people that have, let's say, a more minor on the scale of physical disabilities, sometimes with a transmet amputation across the metatarsals, and hopefully prevent them from having a BK, which then gets into the depending on your state of and licensure, what that would be. So I will fill people in. So I don't have any brave volunteers that want to put a idea out there. The problem with the study, as true as it probably is, was that I did not have an adequate control, because I didn't have a large number of students. So I put it as a quote pilot study, but they wanted a strict control, because in showing the same group of students, the same 2 film clips, there was a pre-concept idea that could have influenced them in terms of the second viewing with the sports scene. So I had to write a paper attacking my own study in the summer, and then I graduated uneventfully with no cap and gown. Sometime in August 21st of that year of '87. And so the only reason that I, again, bring it up is that what really, David, interests me now is we've got, sometimes high-level drug companies and people that are there to sell us stuff that, should know better. But of course, there are obvious agendas that are with industry. And, even at what's happened lately with the pandemic, of how information is being analyzed. So with that sort of backdrop of how important relevant research is, I want to introduce Dr. David Armstrong. He's going to share some of the research that he's been doing, but as a sort of a groundwork piece, David, one of the things I thought would be interesting is there's some new thoughts about what should be valued as evidence-based medicine. I know Bijan was going to give his own sort of quote new definition of evidence-based medicine, but maybe you could give us some context to what you feel evidence-based medicine is and where we are in 2021, and then share some of the work that you and Bijan are doing.
Yeah, sure. And by the way, so where's everyone from? It's like, are these students from hello, by the way, I'm Armstrong. It's good to meet you. I'm a toe doctor. But where are you all? Are these all?
We have some GW.
That's awesome.
Pre-med students.
Oh, terrific.
And,
So so everyone's from GW? My little, yeah, go ahead.
Then we also have some students from Temple, podiatry students, and some, I don't know if the New York students are here yet, but we've had some crossover from the New York school, and I don't know if there's any other podiatry schools that are.
That's terrific. So we have some that are already in the podiatric medical school, and then we have some that are in undergrads. You mentioned GW as well. My little list, our little list is at just pretty close to you guys at Georgetown. So although she's virtual as well. I don't know, they rented a house in freaking upstate New York. I don't know. They're like saved up money, and now it's like this is what they're doing every semester. They go on Airbnb, and then they're like, well, anyway, God bless them. Well, it's good to meet you all. I'm David Armstrong. I am a podiatric surgeon, professor of surgery at the Keck School of Medicine at USC, but I've had a long-standing interest in this field and looking after feet. And I grew up with this. My dad, who passed away about 15 years ago, was a foot doctor, and I kind of grew up in the clinic in the office with him, and I was kind of just given pretty much everything. And to be frank, and I've had no excuses, but to sort of pay it forward. And that's been really my course, to be frank. And it's one of the main reasons that I've gotten into kind of where I am now, and kind of focused on more of an academic, as an academic surgeon now. I've always felt like that this was my way to sort of pay it forward, because I felt that there were so many questions that I had when I was in clinic with my dad back in the day. And that's really where a lot of these questions come from. It's quite literally at the chair side and at the bedside. And whether you are really whatever specialty you are, whether you're a foot doctor or whether you're another specialist, these things always come up. But I think most clinicians don't kind of venture into doing a lot of research like we're talking about. You're going to hear from Bijan in a minute, who's my longtime buddy and former employee. But a lot of what we're doing now. Well, let me start with this for those of you who aren't like foot doctors. So, look, in looking after feet, I mean, I can't think of anything kind of just. I love it, but at first glance, you think this is just what a ridiculous sort of notion. But I can think of two great gifts in looking after people's feet, and for me to try to keep them attached to people, right? But the first is that I think in this era of rampant chest thumping and hubris, I can't think of anything that's more of an expression of humility than looking after someone's feet. And, it crosses all borders and socioeconomic backgrounds and religions. And I mean, even time, right? Tending to someone's feet is an expression of humility. It's an expression in some ways that you don't know something, or it's just, showing respect. So there's that. There's the humility thing. But then the other thing that's a little bit more is a great gift as well, is working out at the end of this, anatomic peninsula, if you will, at the end of the body. It gives you this great gift of perspective, right? My dad used to tell me that, actually, I think my mom told me that the best gift you can give someone besides your love is perspective. And I think that's really true. And the funny thing is you can kind of hang out on that anatomic peninsula, just doing your thing, and your life can be by yourself, right, on that peninsula. And it could probably be pretty relaxing. Or you could choose to collaborate with the anatomic mainland. All right. And we've sort of chosen the latter. And I can tell you, it's great. I mean, my God, we're working on everything from, spray on skin to wearable robots, and pretty much everything in between. And we have a broad interest in this area. But when you think about it, helping people move through the world kind of gives you this broad remit in looking after things. And there's very few people that we don't work with, right? I mean, the guy that the first guy I met here at our place here and at Rancho Los Amigos at the other facility we work at here in Los Angeles, when I was getting recruited out here from Arizona, the first guy that I met that became one of my closest friends is Charles Liu, and Charles is a neurosurgeon, right? And Charles and I, we had mutual interests in brain-computer interfaces, right? And you'd say, what's a foot doctor and a freaking brain doctor, kind of working together? But really, we kind of meet in the middle. And so the point is that I just think that your training and your sort of degree should maybe it should define you in a way, because it's your sum total of effort. But I'll just say that it shouldn't, like, if I could tell you anything, no matter what you do, it shouldn't confine you, right? And that's really the big idea. Anyway, I'm happy to talk about any of the projects that we're doing, but maybe I ought to send it along to is Bijan still there? Or there he is. Did you want to introduce Bijan Najafi? Let me introduce Bijan Najafi.
Yeah, please.
How's that? Oh, look at that. Okay. So listen, way back in the day, and for you guys, it's way back in the day, but this was like in the early 2000s or mid 2000s. But I had gotten recruited. This is to be the research dean out at Scholl College of Podiatric Medicine at Rosalind Franklin University in Chicago. And one of my first hires, I'd heard about this like star out in Boston at Harvard that was doing all this work with work in wearables and work in human motion, and I thought it was really fascinating. And so we ended up getting hooked up together, and I recruited him out to Chicago. And since then, the sky's been the limit. He is probably the top guy in the world in what we now call wearables. And he started by the way, his accent, I'm just going to tell you, is it's impossible to really define. And so if you need me to kind of help sort of translate, I'll do that, like the subscript. But because he started in friggin' Tehran, then he went to Isfahan, then Lausanne. There's a lot of ons here. Then Boston, and then Chicago, and then Tucson, and now friggin' Houston. So, ladies and gentlemen, the pride of Baylor College of Medicine, Professor Bijan Najafi.
Thank you so much, David. Wow, I'm speechless after this kind introduction. Hello, everyone. As David mentioned, I'm Bijan Najafi. I'm actually proud to say that I was one of the mentees of Professor Armstrong, and honestly, every time I'm learning something new from him, so I continue to be his mentee. I'm currently, as David mentioned, I'm in Houston with Baylor College of Medicine. I'm professor in the Department of Surgery and Director of Clinical Research at Division of Vascular Surgery. Naturally, because of my liaison with Division of Vascular Surgery, I have a great interest about limb and lower extremity and wound healing. At the same time, as David mentioned, I'm very interested to see how people move through the world and how we can help them to move through the world. So I'm working mainly on the area of the digital health, wearable technology, remote patient monitoring, and also the solution that can simplify the measurement of that, how people move through the world, as well as creating some innovative solution to deliver care in place when the patient is the most comfortable. That could be actually their home or any place that they are living. Later on, I would be happy to explain some of the research that we are doing, but it's a great honor to be here to speak along with my great mentor, Professor Armstrong, and my friend and colleague, Dr. Perth. Thank you.
Well, I'll put this to both of you. Let's define evidence-based medicine, where we are right now. In either one of you can kind of give your thoughts about it, and I'll just let you kind of take it from there.
Sure. Yeah, you want? Wait, I'll go first, I guess, Bijan. Unless you want to, man, feel free. By the way, or not, or wait. But I think that medicine is like, I think in general, it's just the greatest, I think, profession in the world. I can't think of anyone that's like, can't think of a higher calling, frankly. But it is necessarily like really conservative. And it obviously it's conservative because you don't want to hurt someone if you're doing something new. The old story is never be the first and never be the last. I think I've probably violated both of those at one time or another, but the point is that what we do in medicine is often we do what we were what our mentor trained us to do, or the kind of culture of the program where we trained. And this is, I think, true in a lot of other in a lot of other professions or disciplines. I mean, you can think in the law, if you clerked for a judge, you would probably be influenced by her or him. If you worked for an architect, I guess you probably would be influenced by that school of architecture, as it were. So that's kind of the way a lot of people learn and have learned in medicine in the past. And I think for the most part, there's a lot of good that exists in that. It's almost like an old school, it's almost like a medieval guild, if you will, and not too far away really from guilds. In fact, in England, if you're a surgeon, you're still part of the Society of Barber Surgeons. So if you become a surgeon, so I'm in the Royal College of Surgeons, and it's so the culturally you see these kinds of weird kinds of things, but so you have this kind of training, right? That is very, very, I do this, therefore you copy this, and then you do this. That doesn't always gel really well with, well, why do I do this? And why do I do it this way? In the past, it's really been because I said so, and because this is the way it is. But I'd say maybe over the last generation or two, more and more men and women in medicine and around medicine, within engineering, like Bijan, and within other areas in basic science, have challenged some of these sort of sacred cattle, as it were. And what we have found is that a lot of things that we thought were were correct were often not, because we challenged them with robust randomized controlled trials in what we call evidence-based medicine. And that is how we've made progress, really, I think, over the last 10 years and 15 years, like we haven't made in the last 150. So it's a super exciting time, because I think you have this really kind of robust, sort of old kind of style of training that I don't think is necessarily just bad in and of itself, but I do think it needs to be constantly refreshed and challenged. And that's what's happening now, because we're seeing now more and more good quality work coming out from various facilities. But the trouble is I think for most men and women that are working in the field, they may not be exposed to someone who's doing a lot of research in a given training program. So I'd say to you guys, that if you're interested in that, really seek out that woman or that man that's doing it, and just, like with any mentor, just try to be like her, or be like him. And that's the thing. We need more mentors like that, because that's ultimately, I think, how we're judged. And I think that's ultimately how we really make a difference, is by paying it forward like that.
Bijan
Najafi.
David, gave a great definition. Actually, the part that I really like about what he described it is that is a long-term and lifetime process that need to be updated. So if you look at the theoretical definition, of course, sometimes when we are talking among the in a conference or maybe in some scientific environment, sometimes they consider evidence-based medicine. That means the best external clinical evidence, but it's not just that. It's really combination of several factors. The best definition of evidence-based medicine probably came from Dr. David Sackett. Actually, he was a Canadian-American physician, and he's considered as a father of evidence-based medicine. He defined evidence-based medicine as integrating individual clinical expertise and patient values with the best available external clinical evidence from systematic research. So this is very important. I mean, you need to look at about patient value, what the patient wants. Often we neglect that component. This is very important. It's not just you think that this is best for patient. You need to understand what the patient wants. Also, you need to consider your clinical expertise. Doesn't mean that if there is a technique is coming without acquiring that skill, you can implement it in a practice. And obviously is external clinical evidence that is changing, and you need to evaluate that how you keep yourself up to date to understand that change, because a practice that maybe yesterday we consider or even today we consider as the best available or best clinical evidence for treating a condition, maybe tomorrow we may find out that is not. So keeping up to date and following the research is very important. Of course, if you look at into the depth, the process to extracting the information about the best available external clinical evidence is tricky, because unfortunately we have many publications, as at the beginning Dr. Pearl mentioned, that it may not necessarily considering all the source of the bias, or might have bias by a sponsor, or there might be some analytical plan that is a whole other discussion. But how you identify the level of evidence and determine the best clinical evidence, this is also another different process that maybe later on we can talk about it, about level of evidence 1, 2, 3, 4, and how you decided to select the most accurate information about a clinical evidence from systematic research.
You want to define the levels of evidence as you know them? You mentioned 1, 2, 3, 4.
Sure. Of course, the best level of evidence that we consider, that we considering as level 1, is to start with a systematic review. There are some great resources like Cochrane research that you can find, systematic review, that often is meta-analyzing to find out the best evidence. What that means, usually there are a senior researcher like Professor Armstrong that systematically identify through all the literatures without any bias any other level 1 evidence that's considered as randomized control trial that I will explain in a minute. And then usually for the same condition, we may have the several study that use a technology, like for example, a kind of the type of the surgery, and they report the outcomes. But one problem that sometimes we have is that the study that is done in Professor Armstrong research clinic, since he has excellent study coordinator, maybe everything is very accurate data. And then you're coming to my clinic, maybe I don't have a great study coordinator, or I may not use the latest tools, and I may have different results. So what it does on systematic review is that it combines the results of 2 studies and is doing a meta-analyzing to find out that, for example, what is the effect size of that kind of the intervention. And this is how we can identify the information. So if you find a good systematic review, meta-analyzing, usually you can trust that this is the best available evidence. After a systematic review, another study that is considered level 1 is a randomized control trial. That I don't know that Per, do you want that I go to definition of randomized control trial, or we can discuss later?
How about give a 15-second definition?
So randomized control trial, that probably from its names is clear. That means you randomly selecting a pool of actually patient with a clear definition of inclusion-exclusion criteria, and then randomly assign them, one of them in intervention group and other one in the control group. And everything is the same, and you're following, and then you identify the outcomes, and then you compare the outcome of intervention compared to control group. So this is what we consider as a time group effects. It's not just time effect. That means we are not compared to the baseline, that whether that patient feels better or not. We're comparing that whether this delta that we have from baseline, what is the difference compared to control group? Because we have often the effect of sham group. When you give a surgery, sometimes the patient feels that it's better. So that's why that this is the best level of evidence. If you're designing randomized control trial, often it's even better if we can to blind patient to type of the group assignment, as well as blind the clinical providers, or in particular the person who analyzing data, to remove the source of the bias. This is how we define as randomized control trial. After randomized control trial, that is considered level 1 evidence. The level 2 evidence is considered as a cohort study. What that means? That means that you are not cherry pick your patient. Sometimes the doctors say, oh, this is a good patient, has a good compliance, so let's only selecting that patient for the research. So
Cherry picking. Yeah.
Yes, exactly. So this is not a good research. Usually the good research is that every comer, if it satisfies inclusion-exclusion criteria, should be participate in the research. So this is what we define as a cohort study, that is a level 2. Then the level 3 evidence is what we're considering as a case control series. That means that we have a group of the people already, you assign them to intervention, and the other one in the control. So it's not randomized. So we have some sort of the bias that we may have, but at least we have a control group. We have a reference to compare at least the intervention to that reference. Level 4 evidence, that means that you have just case series. That means you don't have any control to compare the results with. And level 5 evidence is expert opinion or narrative review, something that sometimes we write about it, say that this is what we have. And sometimes it could be animal research, etc. So those all is going to the category of level 5 evidence.
Would you like to share maybe?
And that was like a tour de force.
Yeah, I know, right?
Look at that.
Very succinct.
Yeah, just kind of right. I don't know if it was succinct, but it was very much a tour de force. But by the way, but I tend to be on the end of why say it in 2 words when you can say it in 200. Bijan is usually even quicker than I am, though. That was pretty awesome.
No, it was
Yeah, go ahead.
great, and I think it gives everybody. Now, in that same context, Bijan, if you could, and one of my mentees, Tony Saad, who's doing some work now at Columbia, and I want to congratulate him from getting into medical school up there. He mentioned precision medicine, which kind of goes to the definition that you already sort of mentioned with evidence-based, but precision being even more dialed. So just to give the context of how I understand it, precision medicine is if we have somebody with an insulin pump, and let's say they're 80 points off on the study that was done, but then you have a patient in your office that's only 40 points off where their target blood sugar should be, that precision-based medicine is trying to, as you sort of alluded to, pick the best sort of sets of studies for that particular patient. How do you view, Bijan, precision medicine, and I'll ask you too, David, as being different from the definition that you already did? Is it just sort of an expansion of the moving, evolving of better evidence-based medicine, or is it a slight distinction? If you could just comment, either one of you.
There is a little difference actually here. Of course, the term of precision medicine originally came from genome sequencing. That means that the idea is that each individual is different than another person. So if you would like to see that whether that practice it's beneficial to that individual, maybe we can have the gene of that individual, sequencing that gene, and then we provide a targeted therapy for that individual. In particular, in cancer therapy, this is a very hot topic that maybe some of the drug that may be effective for that one individual may not work on the other individual. So in that case, this is what we are doing. But of course, since then, precision medicine has been evolved. And as you mentioned, now we are using the term of personalized medicine. This is beyond of precision medicine. Personalized medicine, in particular in geriatric population, we know that we have a huge heterogeneity. And the idea is that how we can find out all the available information that we have to personalize care for that particular individual. And thanks to the big data that we have from health electronic records, sometimes we have genomes, sometimes we have history of the care. And with these advanced machine learning, artificial intelligence, we can combine all those information and predict that maybe that type of the surgery may produce a good outcome for that individual or is not. For instance, one of these terms that become very popular, and David and I, we tried for testing the outcome of revascularization on the patient for saving the limb was frailty. That is just one of the tools. We have many tools to define personalized medicine, but one of the tools is a physical frailty that identify that a geriatric patient, whether it can respond good with minimum adverse events to a surgical intervention that we are providing to that individual. But there are many other sources that's coming that now is go to the category of the digital health that based off collection of all those information and big data analytics maybe can help us and guide the physician to decide that what may work the best for that individual. You're at the beginning of the road. There are a lot of research going on that spectrum, but it's very exciting area of research for us as a researcher.
Yeah, it's a super exciting time. And I won't go into any more detail on it, except to say that I think the work that's going on now with what remote patient monitoring, or we call it RPM, is just, man, it's just so awesome, because the things that we used to play with, that I played with back in the 90s, when they used to cost some of these, gyroscopes and accelerometers and magnetometers used to cost, and whatever ohmmeters or whatever, but they used to cost $5,000-$10,000. Now they're almost free, and those sorts of things that can identify where someone is in space and how rapidly they're moving, and then where they are. Now with GPS becoming so affordable and ubiquitous, is both fantastic, but it's also creepy. And so I guess you could say it's creeptastic, right? Because it's a little bit of both. So we have to, as we personalize so much of this, and as we can get so much information now about so many people all the time, we have to ask ourselves the sort of Talmudic question about sort of who owns these data. And I think we as patients, not just we as doctors, but we as patients really need to take control over this and own these data. And that is a big sort of question. It's an existential question for many companies, but it is a critical ethical question, I think, for most of us as patients. And I think we're, as patients, ultimately going to prevail there. But again, if we're going to own all these data, we have to figure out how to make sense of it. And what Bijan was talking about big data, so-called big data analytics, and other methods to measure these things, they can be prone to a lot of biases as well. But they could also be prone to lead to, for patients to have what we call kind of paralysis of analysis, right? To where you have so much information, you just get overwhelmed with it. I was just on this afternoon with a patient. It was the really late at night in the Middle East, and she and her husband were on with me, and it was just like that. They had so much data, they didn't know what to do with it, and they were trying to make sense of that. But in reality, what they really needed was just a woman, or they needed a doctor to be with them, just to work with them and to do things with them and not to them. They were already 5 or 6 steps ahead of that because they had Googled so many things based on the information that they had from their clinic visit at a facility in Abu Dhabi. But anyway, that's just one little example, but it happens 10 times a day. And for all of us, Ben, I know for you for sure as well.
Yeah, I want to sort of tandem that point you just made about how things have become more available. So a few weeks ago, I had a guest. He was an Australian demo skier. His name's Tom Gelly, and he's very instinctively.
What kind of skier? What is it?
He's a racer, and he was a demo skier. So demonstration skier in the ski industry is one of the highest levels you can.
Sounds like it, man. That sounds like Ben, double, quadruple black diamond.
Yeah, like a triple black diamond with
I don't even know.
Twist. Yeah,
I gotta look this up.
So he's really up there, and
demo skier, Bijan. Yeah, that was like when you were in the Alps in Lausanne.
That was when he had Bijan had the one piece. And everybody was skiing with just.
He did. He still does. He has the unitard. Just has a B right on the front there.
So he is very much into foot control, motion, etc. But they have worked with a system called Carve that is a data system, so that at a retail level of what you were saying was thousands of dollars. Now somebody's prepping for a level 2 ski exam, as a ski examiner, can use this Carve system to look at their fore-aft positioning, which is critical in skiing, because you want to be going in the progression of the fall line of the turn at a reasonable price. And here's the kicker, and this is something that I want to, since Bijan does so much engineering research, but what I think is ironic is that we in the clinic, when sometimes I'm looking at a study, now there are better studies that are coming available, but for instance, I wanted to find something on what are the effects of carbon plates on hallux limitus as a baseline. Now, what I did find, because the Australians coincidentally, as you had noted, David, and directed me to, Doug Ritchie pointed me to a study that you had referenced yourself. There's a couple studies that show the use of carbon plates with mid-tarsal arthritis and the improvement. And this is I believe it was a small randomized controlled study. What was interesting though, is there was nothing directly on the first ray. They did show that there was some muted motion in the first ray with the carbon plates. So I'm just gonna say a full disclosure. I'm just gonna tell you why I was particularly interested in it, because full disclosure, had developed something that I think can also be used in tandem with carbon plates, which is what I call a turf toe splint or hallux limitus splint. I developed with a company called OS First. So I wanted to see as a baseline, what is out there? And interestingly enough, it's hard to find a lot of good data on the first ray. There's certainly a lot that's been written about it from back with Dale Morton and hypermobility of the first ray, but there isn't a lot of quantified data of what is the chronology of what's happening with hallux limitus or some other entity in the big toe in what's out there. So with that as a sort of segue, Bijan, why don't you and David share with me some of the interesting engineering things that you have pioneered with an offloading, and anything that you want to comment on, what I sort of threw out there.
Well, sure, tons of stuff, but let's jump on what you're talking about. By the way, I don't want to be putting everyone to freaking sleep. By the way, if anyone has any questions about anything, please, you guys just holler.
Have a chat monitor, so I'll watch it too, if anybody has something they want to post.
This is like adult daycare for me, you guys. But FYI, I just got this big old friggin' protein bowl over here. This is so California, FYI, guys. But this, holy cow, it really looks good. I would have never said this before because this is almost super emasculating, but there's a spectacular looking protein bowl waiting for me as well. I should show you guys because it looks amazing. I can't believe it. I think it costs like a mortgage payment, but it's just right down the road. But anyway, I'm not going to eat that because I'll fall asleep now with such low blood sugar. But if you guys have any questions about any of this stuff, please holler. We're happy to talk at you, but and there's so much going on that we're doing. I mean, it's very broad.
I agree. I want this to be collaborative. Absolutely.
You're so welcome. And I know you guys go through so many Zooms a day, and you'd rather be having the skin slowly ripped off your face than be on another Zoom call or any of this stuff. But you're very, very welcome. You really are. You could put it in the chat box, or you could message us, or whatever you guys want to do. But as you're doing that, again, just holler. One thing I could mention that I thought you could probably use, Ben, that I was working on, and Bijan really pioneered about, 10 years ago now. But in fact, so long ago now that the company that we first started with has already gone out of business 2 or 3 times. But we were working on way back when, in the earlier days of what are people now call intelligent textiles, really cool smart socks. And it sounds goofy, smart socks, but these socks have, in fact, I have a pair in one of these drawers here that's completely bricked, but it was like a $70,000 pair of socks. But these socks had little fibers in them, little fiber optic solutions in there. And there's also ceramic solutions and others that you could use. And they could not only measure pressure and temperature, but the ones that have the actual fibers in them, they can measure, if you think about it, like if your sock is or if your toes moving or a body part is moving, it could measure like a goniometer or a compass, sort of, right? Motion around a certain joint, and you can kind of infer, motion at various joints. And that was one of the most exciting things for me about that thing. And that's long since gone, but now there are devices now that are even more sophisticated. And we've been working lately with one of our buddies up. He's an ex-Microsoft guy, David Vigano. What a great name, David with a little E at the end, Davide Vigano. And Davide is from up kind of by Lake Como. It's a pretty rough place to be from, but he lives now near Seattle, and he was ex-Microsoft, and he started a company called Sensoria, and they have some really cool intelligent textiles, all kinds of different wearables. We've worked with some of those devices, and really some of those next generation devices may be able to help you a lot, Ben. I don't know if you wanted to talk about that, Bijan, if you're still there.
Bijan?
Yes, I am. Sure, I can, but David, you explain it beautifully. Continue.
Well, then never mind. We can go on to something else. Here, but you want to talk about anyway, you guys. For those of you that have an interest in this, some of you may be aware. If you're an undergrad, you may not be, but diabetes is obviously a pretty big problem, not only in the United States. There's about, give or take, 35 million people with diabetes in the United States. There are about 100 million people with diabetes or pre-diabetes. And about half of them will develop neuropathy, where they lose what one of my mentors, Paul Brand, used to call it the gift of pain. So they can literally wear a hole in their foot, like you or I, we would all wear a hole in our sock or a shoe, even if it's a smart sock. And that hole, that's called a diabetic foot ulcer. And we had a technical review recently in the New England Journal where we found that, these sores happen now around the world every 1 second, 1.2 seconds, give or take. And it's getting more common. And then half of those wounds get infected for various reasons. And then once that infection happens, then there's an amputation every 20 seconds now, 20 seconds around the world. So we'd like to say that time's up for this, right? And we'd like to push back the clock. And there's a lot that we can do. There's a lot we can do surgically to treat these things, to debride them and to reconstruct them. I don't have time to talk about that, but there's a lot of cool things we're doing there. There's a lot of things we can do medically to optimize people's glucose control, their lipid profile, kind of anti-thrombotic kind of profile and stuff to get them on best medical therapy. And then there's stuff we can do mechanically to kind of spread force out over a larger unit area, if you will, and over time even. And that's called offloading. And so that's been an area of interest amongst many areas of interest for me for some time, since I was, training for so long, because it's been something that we all talk about, but we don't do a lot of it. So the best device, the best thing that we have right now to offload someone, to take pressure off of the bottom of their foot, believe it or not, is a cast. And it's called a total contact cast. And that's actually still my favorite method to offload people. But the trouble is that even though it heals people really well in randomized controlled trials, we and other people have done, it's a cast. People don't like it because it's hot and heavy. And it's hard, and doctors don't like it because it's hard to put on. But so there you are. So people have moved from using casts a lot to using something that's easier, which are like those boots that you might see someone wearing on the sidelines, maybe in a basketball game or a football game. It's called a removable cast boot. And those things are really great because they can reduce pressure like a cast. And it's easy to put one of those on, unless you have an aversion to Velcro, you could probably figure out how to put one of those on. You don't need any training. The trouble is that because our patients they can't feel pain, they're more likely actually to take that device off. And back in the day, 15, 17 years ago, we measured that in the early days of wearables. And we found people were wearing that removable boot, believe it or not. And remember, these are people with wide open wounds on the bottom of their feet. If you saw this, you guys would have this visceral reaction to it. But they were only wearing that boot for about 28% of their total activity. So the other, 72% of the day on average, patient folks, almost 3/4 of the day, these folks were walking around either barefoot or with something else on their foot. And these are people with open wounds on their feet. And again, so it's dangerous.
David, can I interject? Who came up with the zip ties to measure compliance as one of the elements of one of the?
Yeah. So again, it's just kind of marching through evidence-based medicine and sort of logic. We're just doing these individual studies. The one device offloads as well as the other, but it doesn't heal people as well. Why? Because they're removing it. Well, but people aren't using that cast. Only 2% of people are using the cast. More people are using the boot, but it doesn't heal people as well. Why? Because they're removing it. Maybe we can make that boot irremovable. So that led us, in another study we did in the middle of the 2000s, to just putting like a zip tie on that thing and kind of ensuring adherence to the thing. It's like, and that created what people now call instant total contact casts, or ITCCs. The trouble with that, though, is that you're doing something to someone, I think, and you're not doing it like with them. And that's a very California thing. I know it's kind of touchy-feely, and I should be eating my protein bowl, my acai bowl, while I'm talking to you about that. But truly, I think it's important, right? And I think doing something with someone is a lot more fun as a surgeon or a physician or anyone than doing it to them. And so that has led us now, and with Bijan and me, we just got this big NIH grant to look at this smart boot, which has that intelligent textile stuff that I told you from that Sensoria team, and they're kind of rejiggering a boot that already exists to be intelligent, certainly more intelligent than the toe doctor that's putting it on the patient. And so we're testing that. We're testing a removable device, a standard one, a regular boot that has some sensors on it, but we're not giving, but we're only looking at that stuff later. An irremovable device, and then a device that is a smart device that is giving people a little information that tells them when they're being adherent and they're not, and when they're not, and kind of coaching them and saying, "Hey, good job, man. Good job, Ms. Garcia. Good job, Mr. Smith." And kind of giving them a bit of a thumbs up and kind of, or thumbs down, and gamifying it a little bit. And to overuse the term gamifying, because I think overused for the last 15 years. But the thing is that that's the big idea. We're hoping that we can be improving care by doing something like that. And we think that that kind of thing is going to give us so much information about how people behave and react. And we'll really be able to, just like Bijan and you, Ben, said, to like personalize care for this patient population. And so that's really, really exciting. Plus, there's tons of other things we're doing in that study by collecting data on how folks move through the world and kind of being able to predict all kinds of things that where we can help them, I think, help them heal and hopefully remain healed. Bijan Najafi?
Yes, David, you gave an excellent example for evidence-based medicine. If you remember, we said that evidence-based medicine has three components. One of them is best evidence, but we have two other components that unfortunately often we neglect them. One of them is clinical expertise, and the other one is patient values. Impact of patient values, I would like to emphasize on it more. So as David mentioned, currently total contact cast, it provides best evidence for healing the wound. But if you look at, in point of view of practice, David Armstrong published a great paper that shows that only 2% of the outpatient clinic in the United States practice total contact cast. Because maybe time consuming, maybe make a mess. So if you look at on the aspect of clinical expertise or practice, is not very well popular. But most importantly, patient may not like it. When all the time you should wear the boots, that means that at night when you don't need to have offloading, also you should wear the boots. You cannot take shower. You cannot inspect the wound. So that's the part that actually, if you look at patient values, it doesn't satisfy that criteria. So despite that, total contact cast may provide the best evidence for wound healing, but since may not satisfy two other categories, maybe this is not necessarily evidence-based medicine if you look at the traditional definition. But that's a way that maybe we can find out a better or creative things to involve patient values. Maybe that kind of the aspect of a smart boots that can help us to understand that whether the patient really remove their boots or not, because those boots are smart. We can detect it that if somebody is walking with their boots or not, and we can reinforce them. And if they don't have compliance, then through remote patient monitoring, we can find out about it. We can engage caregivers, the relative, as well as care providers to reinforce adherence, or maybe switch them to the total contact cast. But if they have a good compliance to where they're offloading, and when they are sitting or when they are on the bed and want to sleep, they can remove the offloading. Maybe that's a way that might be allowable. We may have still good outcomes on the wound healing, and also we satisfy the criteria of the patient values. So we can give this example over and over. And again, if you look at about the personalized medicine, I'm personally very excited about it. That can really transform the way that we are delivering care to the patient. I would like to give another example that actually it was created thanks to David, fantastic works that he has done for prediction of incidence of foot ulcer. If you look at the traditional way to provide care to somebody who has high risk of foot ulcer, is that we need to regularly actually schedule an appointment for that individual to come to clinic. So we check the risk factor, removing callus or any other factors that we need for that individual. The problem for this is that, of course, many healthcare systems may not afford that to cover, for example, seeing patient every 3 months. Patient also might be problematic every 3 months coming to clinic. And often also we may miss interval to provide timely care to this patient. So what we can do about it to make these more personalized? David Armstrong actually find out that if you look at the temperature on the feet, temperature is a good sign of inflammation. We know from great work of Paul Bland that the skin is heat up before breakdown. And David Armstrong and Larry Lavery demonstrate that if we monitor skin temperature and provide this information to the patient and care providers, we can successfully prevent reoccurrence of foot ulcer. But now there is a company that designed a simple, smart bath mat that you can place it next to the bed or in the bathroom, and it would be enough to stand on that mat for 20 seconds. And what it does, it measures the temperature on bottom of feet. They have an artificial intelligence algorithm to isolate hot spot on the bottom of the feet. And then by streaming this data to a cloud, it can predict that what is the risk that that individual predict foot ulcer. And we did this study actually when I was at the University of Arizona working with David, and we demonstrate that this technique can help us to predict incident of foot ulcer with 37 days lead time. That is sufficient window to provide timely care to the patient, and also has a very good accuracy to predict them with 97% accuracy. Of course, we have a lot of false alerts. So we have poor specificity. But if we consider this as a triaging of the patient that should be immediately seeing the clinic or receiving a telemedicine consultation to reduce the risk, that might be it's a good way. This is the way that we can personalize them. It's not just saying that every patient every 3 months should come to clinic. We can decide that who should come urgently to the clinic to provide care for them. So we have many of examples that's going on in the research through this interdisciplinary collaboration and leveraging the technology that become cheaper and cheaper to provide more personalized care to the patient that also is aligned with their patient values.
That's great stuff. I wanted to segue to what you had done some work with telemedicine and compliance. And I wanted to share a little vignette that happened to me over the weekend with a telemedicine visit. Certainly telemedicine is here to stay with the pandemic. It's not, it's out of the Jack in the Box. We all pretty much know that. What I think is interesting is some of the nuances that are happening with our interactions with our patients with telemedicine. And I know that, Bijan, you're doing a study, but I think you'll find this funny. So I'm at Breckenridge last weekend taking a much needed R&R from all that we've been dealing with the added stresses that we all have been living with and our patients have been living with. And this was a virtual visit that was set up in the morning before I was going skiing. And I sent the patient to my office that had lateral foot pain for an x-ray. And my tech took it, and I took a look at the x-rays, and we set up a follow-up time that we would discuss the views. And there was some back and forth, and my patient was a little bit nervous about the idea of telemedicine, but I reviewed the x-ray. I deemed it on the 5th metatarsal base not to be a stress fracture, but a stress reaction, which for those of you that don't know isn't a full fracture. It just implies that there's some bone activity, and we can see that sometimes with the more fuzzy margin on the outer eggshell of the bone, of the outer cortex. And I was explaining this to the patient, and literally by the time the communications had happened, I was now on the mountain and I had pulled over to a stand of pine trees. Now, this was the swing point in the visit. as I was explaining and explained it not once but twice about the idea of this modulus of what's happening between a stress reaction and how it could potentially move into a fracture, because of the telemedicine interaction, the patient became nervous and was on the ledge of wondering whether this was the right idea for her, because now there was a new term that was introduced. She was worried about, what does this, stress reaction mean? I gave her the treatment plan, which was the option of either a surgical shoe, a boot, and then we even talked about a stiffer shoe that we had as an option. And she opted, and I mentioned also you're going to need to use a cane to, on the other side. And she explained how, one person told her to use it on the same side, and I said, no, that's not the way you were doing it. You're the right way initially, which is the opposite side to offload, the side that's injured. So with that as a segue, Bijan, I know you are doing some research. Now, fortunately, I was able to reschedule this patient till tomorrow, in fact, and we're going to, review how she's doing, and then I'll get the hands-on, to sort of solidify the visit. But tell me about the research that you're doing with telemedicine, and David, if you could add any words after Bijan speaks about some of your experiences, because I know you're doing telemedicine all over the world. So, Bijan, why don't you start?
Sure. Maybe I can share my screen if it's okay with you to
Sure.
give a simple example about.
I think Sonia can make that happen.
Yes. Can you see my screen?
Yes.
So this is, as you know, VA actually is one of the leader on telemedicine, and we are very lucky that we are collaborating with VA Houston, that is one of the largest VA. I'm guessing we were one of the first that we implement the concept of telerehabilitation. And this is very simple. This is exactly what's happening here. So through the video, we coach the patient. We ship and mail every exercise tools for that individual. This is for the patient who has COPD or CHF, heart failure, congestion heart failure. So first we provide education for them, then we provide some respiratory exercise, then we guide them how to do the exercise. This is one of the great value of actually telemedicine, because if this patient can benefit from exercise, but since they have problem to commute, to come to rehabilitation center to receive exercise, they have a high rate of the dropout. If you look at the literature, we have over 70% dropout on the exercise that is fully reimbursed by insurance by those patients who are frail because they cannot travel or commute to the exercise traffic, but they can get these over telemedicine. The same way that you are having face-to-face, you can provide actually remotely. And that actually, it can help. Actually, we show the results that how effective for those patients. Usually we are using one of the outcomes that we are using is 6 minutes walk distance test. It's a functional capacity. As you see here for our participant, we have improvement about 16%. That is medium effect size, and even show that we reverse some of the frailty. So this is a traditional way, but it's very popular to using the data. So now we said that how we can make these even simpler and making virtually supervised, and also adding some gamification that Professor Armstrong mentioned, that to even engage them more in the exercise. And this is a much recent actually program that we developed. How it's work is simply we ask patients to play a game. And how we do that, we attach a sensor, variable sensor, is the same sensor used in the smartwatch or smartphone. They become very cheap. And these sensors act like a joystick that we use to play game. But you can use these to attach to the joints of interest, that by movement of that joint, the patient can play the game. So for instance, this is one of the game that we designed. It's called a space shooter game. Actually, when I was a kid, I used to play that game using Atari. So what it does is that when you're doing your feet on medial lateral direction, you can navigate aircraft to the left and right. And when you're doing very quick dorsiflexion, plantar flexion, you can hit, and you can actually hit the target on the screen. So you need to be very fast. And actually the patient, they're doing very well. Even those who have rigidity, they do very well. And we did a study that this is very good exercise to improve venous return flow. That is very important to prevent DVT, as well as actually activate the calf muscles. So on the computer laptop that I place here, and you see some sensor that are EMG sensor. We measure activation of muscles. And I don't know that the screen is small, but it's very nicely activate the calf muscles. So you can develop the same game for different joint. And actually patients really like it. This is the second exercise that we developed for kind of the like management neuropathy, is kind of the perception exercise for improving perception of position of joint in space. So for that game, so simply by dorsiflexion and plantar flexion of the foot, you navigate a bird on the space. So if you, for example, plantar flex, the bird is going up, and if dorsiflex, the bird is going down. And then you can navigate through the building and obstacles. Sometimes you need to be very fast. You need to quickly move to quickly bring the bird down. And that also, as you can see on the EMG signal, is good to activate some of the muscles of interest that we would like to have. And for adding resistive exercise, actually, we are using this sitting bike. It costs $20 on Amazon. And you integrate the same flying bird, but simply when you bike fast, the bird is going down. When you stop, the bird going slowly down. If you bike in reverse, the bird quickly coming down. And you can have these to any joint. So this is, I believe that it might be the future of some personal exercise. We are hoping that for a patient who has wound and may not do weight bearing exercise, at least they can do that exercise to keep the muscles active. Actually, originally we designed this exercise for, this is of course another exercise, another way that we have, but we use this for hemodialysis patient. And we demonstrate that in hemodialysis, when they are receiving hemodialysis, they can play that game, and this is effective to reduce their depression. Also is effective to actually improve their gait and mobility. It looks like very simple exercise, but sometimes those patients, since they are not doing anything, this simple exercise is already great for them. They don't need to go to the gym and, oops, I'm excited. So, and running on treadmill, they can just play those kind of this simple game. And again, we can personalize them to the need that they have. So by the way, we just got a grant from VA that we plan to develop the same program for COVID-19 patients who discharged from hospital and they may have muscle loss in lower extremity. This is a condition that we call it as myopathy. Some of them may develop neuropathy because of ICU. When they are bed rest for prolonged period of time and intubated, they may have this condition of the neuropathy. And unfortunately, currently, we don't have a good solution to help them to recover fast. Those conditions are currently on acute condition, but if we don't provide anything for them, it can turn to chronic. That will be very hard to reverse them. So we are hoping that by providing these kind of the exercise, we can help them to reverse their neuropathy, those numbness, or maybe lack of perception feedback that they have, and regain the muscles that for that patient. All of those tablets has telemedicine. That means we video call patient, because all of them that video call like FaceTime that you have in iPhone. And then when we video call them, we can have a control of the screen. We can guide them how to do the exercise as well as how to attach a sensor, but everything is automatic. So those tablets are on kiosk mode. That means that this tablet uniquely used for that purpose. When you turn on, automatically the interface of the game is actually displaying to the patient. So even if they are non-tech savvy, they don't need to do anything. So just they need to turn on and turn off the tablet, and everything automatically is done and can be coached remotely via telemedicine.
Well, Bijan, I mean, this is genius. I think you hit it on a couple different levels. One, David's idea of humility, where you're ingratiating yourself to the patient by having them participate in a game that's fun. But do you play chess, Bijan? Are you a chess player? Because I
Yes.
think the brilliant part of this is you've also what we would say forked the patient, held held the bishop and the rook, and that now you have your sort of complete mechanized way that you've recorded what they've actually done. So I love that part of it. The one thing I wanted to sort of ask you about this in particular is, with the idea of use it or lose it with proprioception for neuropathy, what specific findings are you getting so far in terms of how much can we really gain with this gaining, where we're doing fine dexterity moments with our feet and lower leg muscles, from what you initially can see?
So actually, we are really at the beginning of the road. So we just tested
Okay.
feasibility. We don't have the results, but actually in another study that was for ICU patient with critically ill COVID-19, because we talk about this pandemic, but sometimes we may not realize that unfortunately, even if the patient discharged from hospital, often they are dealing with the post-COVID symptoms or syndromes. That is problematic. And of course, ideally, we need to start some intervention in the ICU to avoid those kind of conditions. And that's kind of the method that we try to implement. We just finished a study. Again, I share actually my slide for exactly prevention of neuropathy and myopathy that I told you. That was based on functional electrical stimulation that we apply in the ICU patient. That was a small study. Again, it was randomized control trial. We randomly assigned a group in the intervention and another group in the control group. We provide electrical stimulation. I don't know, you can see on that picture that attach on each of the calf muscles. That what it does, it's activate the muscles. They are not electroshocking patients. These are very small magnitude, but they are very good to keep muscle activated. And then one of the device, of course, for the sham group, it was non-functional. Even the person who applied didn't know that it's functional, because when they turn on the device, it's like everything, it works, but actually doesn't deliver electricity to activate the muscles. And use that technology that is based on near infrared spectroscopy that help us to look at the tissue oxygenation. It's like the pulse oximetry that you're using on your finger, but this is a near infrared that can penetrate in the skin, and with 1 millimeter under the skin, you can say the level of oxygenation. But that's kind of the method that we have, and we follow them for 7 days. And of course, we demonstrate that how well this electrostimulation can keep the oxygenation. This is earlier results, but now we have final results for all the subject. But actually, we demonstrate that if we provide that treatment on daily basis, 1 hour per day in the ICU patient, we can preserve their muscles. But the group that didn't receive that treatment, they have a significant decline on the muscle function, and they developed some sign of the neuropathy, and one of them is related to the poor perfusion, tissue perfusion that they have in the leg. Because we know that to have blood flow to our feet, we need to walk, we need to move. But somebody who is in ICU and is bedbound and doesn't move at all, their leg, this is a problem that's happening. There is not perfusion, there is not oxygenation. They start losing the muscles and the nerves start to be damaged, like the same condition that we have in diabetes population. So we are very excited about that kind of the research and the treatment that we can provide for this patient population.
Hey, Bijan, I just saw a question from Kavita Rajenjan, who had asked if these gamification techniques are really only specifically related to exercise, or if they could be applied to other areas in medicine and surgery.
Actually, it's a very hot topic. It's applied to everything. Stanford, for instance, they have a dedicated actually research program on gamification and already implemented. If you have a smartwatch, probably notice you that sometimes give you a badge when you reach your goal. It's like, congratulations, hey, you reached the goal. And sometimes encourage you, hey, you have 7 days in a row, you hit your goal. And you can sometimes share this in social media. So those are gamification. So gamification doesn't mean that you should play a game. Actually, all of them, they are game, encourage you. Why we calling game? Because at the game, we get some score. We happy that we reach to some goal and we get some badge in return or some reward. So this is a reward-based aspect. And that implemented on every aspect of the treatment. A complete different example is ongoing project that we have for patients with dementia that actually we created a smart home for them. For instance, in the bottle of medication, there is a smart tag like this barcode that you are using that one, and the patient wear a pendant sensor. So when there is a time of medication, we can see that the patient actually interact with this bottle of medication and taking medication. And then we use these to encourage actually the patient, give them the badge, or creating a smart calendar for them that they don't miss those events. And this is not just that. We manage all the instrumental activities of their living. We have even developed an app. It's like a spy that we install on their computer or cell phone, of course, with their permission. It's ongoing research, but we can check that for how long they have phone conversation, whether they are using their social app or some of the apps, how much they spend on it, whether they watch some photos or not. And based on those kind of information, we develop an algorithm that can evaluate their cognitive preserve. There is a tablet that is voice enabled for the patient that actually share, for example, the grandkids picture. Sometimes we provide audiobooks, and there are a lot of gamification features that engage them on daily activity, encourage them to do the exercise, and many more. This is, for example, one example, but you can have over and over examples.
And so much of this stuff, I mean, there's so much to this, and it's really a rich area, like so many other areas, but so much of this does not really fall into the realm of medicine, surgery, mechanics and science. It falls into the realm in many ways of behavior, even of marketing. And I know that sounds crass, and I don't mean it to sound that way, but in fact, we've been working more and more closely with our Marshall School of Business at SC here to the same people that do marketplace and all the other things, to figure out ways to nudge people to help them do what they already say they want to do, but maybe aren't, or maybe what we say. And there's all these elements of negotiation and kind of feedback and positive feedback and how you can nudge people into doing something slowly, and you can affect change kind of gradually. It's kind of like changing eating by slowly shrinking the size of a plate, for instance. But we're talking about doing that almost electronically to try to signal people into different types of health behaviors that you've already spoken with them about, that you want them to do and they want them to do. So it's such a cool time to be playing around with all this stuff and to be learning about all this. It really is it's just great.
In terms of approachability with the device, Bijan, that you're talking about with the electric stim with the neuropathy, is it something more than a standard TENS unit that you're using? I'm guessing it's more sophisticated than that. And how approachable and marketable with both patients and insurance companies does the device that you are using for the electric stim for better outcomes with wound healing, et cetera, give us sort of the lowdown on that aspect of it.
Yes, it's similar to TENS unit, but at the same time, it's not. I mean, all the TENS units use electricity, but it depends on the shape of that electrical signal that does matter. If you look at low-cost TENS, they are using like a square shape. So what that means that when you have a square shape and a square shape that is not as smooth, it gives this sensation of electroshocking. And that's not a good feeling. And the patient, they don't like it. But there are now some companies that redesign those electricity, adding some kind of the burst, very smooth way to remove this sensation of electroshocking. And now it's feeling like somebody's massaging actually the foot or the muscle. So it's a good feeling actually, rather than to be bad feeling. And they become closed loop. So the low cost TENS, they don't check, for example, the conductivity of the skin. And if you don't check the conductivity of the skin, the amount of the current that's going and penetrating the skin could cause bad feeling. For example, dry skin, it doesn't have a good conductivity, but actually a moist skin, it might be different. So when you are using the same magnitude amplitude on somebody that's adjusted with the dry skin, maybe doesn't work on a moist skin. And that's a part that make it a little challenge to make those technologies home-based. Usually to get a good outcomes, the patient should come to physical therapists to apply, to adjust those parameters that sometimes very sophisticated to make this happen. But now there are some new technology that use the concept of a closed loop. That means that they measure skin conductivity, they play automatically with parameters. There is some artificial intelligence into it and adjust automatically the magnitude that is needed for that individual. And actually we test this for wound healing as a home-based therapy. And the patient really like it. And actually we just finished it. The paper is currently under review to demonstrate that these kind of techniques is effective as an adjunctive therapy. Again, it's not a replacement of therapy, it's a supplement therapy. And it shows that compared to control group, it seems that the speed of the wound healing for the patient. For ICU, when you are using for activation muscles, there is other parameters that you need to pay attention to it. Keep in mind that if the patient, if even in athletes, this happening, if you're running too much and these muscles, they are burning oxygen in the tissue. And if you completely disturb this supply of oxygen in the muscles, instead of gaining muscles, you start losing muscles. So it's damage the muscles. You're seeing these on some of the patients with peripheral artery disease, that when you force them to walk on treadmill to improve perfusion, sometimes you may damage the muscles as well, because muscles need to have oxygen and nutrition to survive. If you force them too much and you burn all the oxygen out of the muscles, you can damage it. And for ICU, that was the biggest challenge that we had, how to adjust these to ensure that we are not burning the oxygen on the muscles, because the patients sometimes are unconscious. And if you activate the muscle too much for 1 hour, you can start damaging those muscles. And that's a part that we were lucky to have technology using this near infrared camera that we personalize for each individual. We apply them, we ensure that that doesn't cause a negative impact on the oxygen level of the muscles, and then we adjust them. We were safe to say that this is what we can do it. But for reaching to that level, we did it a lot of in laboratory tests to come up with the right setup. But if you consider that one, we got some very good results out of it.
David, I wanted to jump gears a second on something that you're familiar with because you've done so much vascular work, but also something that I think is very important that you mentioned, and you have another colleague that's doing research on the endovascular COVID link. Can you talk to us a little bit? You updated me several months ago, but there's maybe been even more, and particularly with what just happened with Johnson and Johnson, those reports. So talk to me a little bit about is sort of the endovascular link, and a little bit more about where you think it's going, and anything else that you can share about it.
Well, sure. I think that, I mean, this is a little bit kind of inside baseball kind of stuff, but broadly, I think that, we've been talking about this, and I think the data have borne it out that, a lot of COVID related significant complications are really vascular complications, and it happens to be transmitted through the lung. I mean, even the lung parenchyma are being attacked in a, I mean, there's a vascular component to that. And a lot of these patients that we're seeing just, I mean, just last night, actually, I'm actually getting texted about one right now. I'm just trying to respond to, it's coming into our emergency department, but patients that are having really significant thrombotic, kind of prothrombotic sort of presentations. And one of my friends and partners, Ken Ziegler, he's a vascular surgeon, world class. He was just working on a patient of ours at our county hospital, and that patient had a kind of a thrombus that was just massive and decidedly unusual. And this problem that we're kind of seeing with these acute on chronic cold legs has been pretty common or more common than we'd like to see in folks with COVID. And we think that's because these patients are just, there's a real prothrombotic, pro-inflammatory kind of condition going on. So, and that may be what we were initially seeing early on, maybe a year ago, when people were talking about, COVID toe and things like that, where you'd see little flecks that looked almost like little emboli. So, but yeah, and so the treatment of this, I think, has been to more aggressively kind of treat that medically and surgically. And I think we're only starting to learn about this as you're getting into we're going to learn more about this with some of the COVID long haulers, which is maybe a pretty big percentage of patients, more than we'd like to see, who are having long-term symptoms post COVID. And these are young folks and older folks.
I know there's some people that might have some questions out there, and I want to, because we've been at it for about an hour plus, and I wanted to just allow people to chime in and ask some questions to both clinicians, if there's anything out there that people want to have them expand on. Anyone? Not yet, not just right yet. Well, Bijan, do you want to, Tony, go ahead. Tony, by the way, is somebody that spent several months with me in the clinic and has helped me. We did something on CBD. We did a little paper that we did on the effects of CBD. And Tony now is at Columbia Medical School, or, well, you explain where you are. Is it a master's, Tony? Go ahead.
So I'm studying nutrition right now. I'm doing cancer research at New York Presbyterian. And one thing in research, which I thought you guys hit on in really unique ways, was the issue of, the electronic health records and the electronic medical records and patient access, both patient access and also researchers' access to these information, because the reality is there's so much data out there that can be utilized, but of course with permissions and whatnot being a problem, I wanted to ask what your opinions are in that long term when it comes to other research outputs and things that we can tap into that could help in issues such as precision medicine. Thank you.
Bijan?
Sure. That's an excellent question, but it's not very easy to answer, to be honest. So when it's coming to electronic health record, I mean, as you know, we have HIPAA regulation. So it's not something that you can easily have in access to them. But at the same time, this is maybe a good part of NIH, that when you get funding from NIH, you need to share the database that is completely de-identified. So you address the aspect of the HIPAA compliant, and then this database is available to explore them. There are already several large databases that you can explore them, and sometimes you can reach out to the PI and getting additional details. But if you would like to look at electronic health record, this is what we are doing in the hospital base, but it's some inside circle for those people who has CT training, the training that's required to understand the concept of doing research on human subject, understand the consenting form. And often we are doing what we're calling as retrospective study. We have a good research question, we get approval from IRB, And then we are going to electronic health record respectively to understand what's going on and what we can extract from these data. When we have prospective study, sometimes it's much easier because from the patient already we get the consent form and we get additional consent that we are allowed to use electronic health record of that individual even after the study. So that is the language that we use in the IRB. Of course, we have a strong justification that why we are using those information, and that help us to explore the electronic health record.
I see another question. Tony, did that answer your question?
Yeah, no, that's great and very applicable, like all the future work I want to do with Dr. Pearl and others. So I really appreciate that, Dr. Najafi. Thank you.
I have a question for everyone from Sonia about what should a student look for if they want to get involved in research. Let's say they're in undergrad. They're not quite sure what direction they want to go, but what things to keep that they should keep in mind so that it's a good fit for them and maybe the person that they're doing the research with.
Well, actually, speaking of research, I'm not doing research. Actually, let me just send this note to this this emergency department right now,
So maybe in meantime that David.
Oh yeah, I do. Well, yeah, I'm back now. I just was. I'm taking care of patients this way. It's safer if I take care of my patients at a distance. Statistically, I think my patients are going to do better. Anyway, this is such a good question. It really is from Sonia. And the bottom line is that none of us have any idea what we want to do. For the rest of our lives, we may think we do. I certainly always, thought I did, but I've made so many changes over my life, back and forth. But what I would say is just, and this depends on your personality, but I think look to things that obviously interest you, now, but really look to ideas that you think are big ones for the future. And then just as important, if you can try to identify, and again, it's so hard to do this externally, if you're like surfing, the web looking for a mentor in a medical school, website. It's almost like, swipe left, freaking swipe right. It's impossible really to make these kinds of determinations about like someone that's going to be a great mentor. But a lot of it really does have to do with personality. I mean, I think that I like to say to our trainees that, they choose us before we choose them. But when that does happen, we take the mentoring really seriously, because I think that's like, obviously we don't take ourselves very seriously, but we take the work seriously. How's that? And I think, and a lot of that work is in mentoring people, because I think ultimately that's how you're judged. I think any mentor, any woman, any man that's doing work in this area is not judged on how much money they've brought in, although that's all freaking great, how many papers they've written or how many lectures they've given in how many countries or how many surgeries they've done or whatever the heck, how many awards. Ultimately, they're judged by what I call, just like you have your kids ultimately, and they're like your personal progeny. I call my research kids my professional progeny, and it's the same thing, and it's a sacred thing. And when you find folks like that, it mandates that you get out there. And maybe that means right now, unfortunately, getting out there virtually. But, just ping the heck out of people and just keep bumping into things until they either give way and you enter into something, or you find a way around something and you find your way into something that fascinates you. And it's, by the way, it's okay to change something 3 or 4 or 5 times. This is like a big old buffet for you. It's like a smorgasbord. And the goal for you guys is to sample from that and find what you like. And something else is if you happen to get into someone's research, like into a lab, let's say if you're doing basic work, or if you're getting into kind of a clinical research setting, you're going to be bumping into a lot of other women and men, and that you may say, holy cow, what's she doing? That's pretty great. I want to be like her. Or God dang, that guy, whoa, man. And that should be you, like all the time, like, wow, because I know when I was rotating, I want as a clinically, I wanted to be every specialist that I rotated through, pretty much for every single one. I mean, even frigging pathology, which with dead stuff, I even enjoyed that. And who enjoys that, by the way? Maybe some pathologists, right? But they're probably pathological. But the point is that just there is no answer to this question except energy. I think just identify someone that you think is going to take an interest in what you're doing, is going to mentor you. And if you're in a unit that doesn't have that, then it's okay to find another one. Or maybe check yourself, right? Am I putting everything I can into this? And ultimately, that's going to lead you to I think to a good place. And I think what you're going to find is you'll find that this research path, it's all about people, right? And it's a world wide web of people, just like it's a world wide web of hyperlinks. And that woman or that man that is 1 or 2 or 10 or 15 levels above you on the wiring diagram at that time, these are all people that are going to be really important for the rest of your life, and save them, right? These are, and that's sacred too. And that's not cynical. And people call it networking or whatever you call it. It almost sounds like it's a transactional thing. And, maybe it can be, but I don't think it should be. I don't think it is all the time, because the people you're with going up and around and down, there are a lot of people that may never be able to punch your ticket for something, but you had a relationship with them, and then all of a sudden 15 years later, that woman is associate dean of X or chairperson of that, and you had no idea, and oh man, what the heck, and all of a sudden, boom, magic. So I know I didn't even say anything. I just had some soliloquy, and it's likely because I'm hypoglycemic. I don't have my acai bowl yet, which I'm really jonesing for, FYI. But I think you get what I'm saying, is get in with someone that's like-minded with you. And even if they're not like-minded with you, just someone in that lab will be, and almost whatever you're doing ultimately is going to be positive, and just keep moving. And that's the way you're going to keep learning. I mean, really, and you'll find this kind of moving forward. Again, I've said almost nothing, and it's been a lot of sound and fury, and has signified essentially nothing. That's my word from the bard.
Well, sometimes just the grounding statements, David, like you started with, the humility of the feet, and just why we do what we do, and
man, I should have
by how much
stopped there.
Money we have when we're 6 feet under, or what our legacy with what we leave with people, But Bijan, you have anything you want to add to that?
David nicely actually said everything. It's like a personal medicine, so everything is personalized also for the research. Of course, some tip that I may have is that if you have opportunity, try to do shadowing, doing internship. We have a lot of undergraduates that came to our team, and through actually interaction and hands-on on the research, they find out that whether this is an area they like it or not. Unfortunately, during COVID-19, I know that on campus shadowing, sometimes they may have some limitation, but now many of lab meeting that they are talking about the research now is over Zoom. So just if you're interested about the research of every group, just ask them that when they have lab meeting and whether they can share their Zoom link with you so it can actually pop up and see that what they talk about the research. And often, in particular for undergraduate student, it would be good to team up with a graduate student, with a postdoc, because they have good time. You can spend them and you can learn it. You can engage in publication that sometimes it might be good if in particular you would like to apply to good medical school, or in particular later on when you would like to match a good residency program, having a couple of publications in the CV may help. About the area of the research, I might be biased, but I believe that the research or even the medicine, it's going toward interdisciplinary. I'm engineer, but my appointment is Department of Surgery. How odd it is. And this is the reality. I mean, all the disciplines that are coming together. And I believe that maybe those who are more engaged on interdisciplinary research, maybe they may have a better future in their research. I don't know. This is my personal opinion. It doesn't apply to everything, but maybe for the topic that it's cross-disciplinary, there are people from different disciplines that working together. Maybe you can gain more from them.
Yeah, and listen, if you get in there and you do what you do, what's great about academia, and it's not in it's and some may say this isn't necessarily true, but I really think at the end of the day, it's become this way. It's more of a meritocracy in academic medicine and in research than in a lot of other areas around the world where there are enormous biases. Are there ones in medicine and academia too? Yes, but if you can bring it, are people gonna judge you based on your work product? Yes, I really, really believe that more in academia than in many, many other areas. Although there are obviously enormous barriers yet to traverse, but it's such an exciting time now for all of you, and it's so much better even than when I got started. And when I got started, it was pretty great. And Bijan the same way, man. I mean, and you see a guy like that, that's a world class, and he's not in an engineering department. He has he's hanging out with the surgeons, because otherwise, if he's hanging out by himself, then he's going to solve yesterday's problems maybe tomorrow, right? Instead of getting in there and people like me are like struggling, and I'm saying, well, God, what's that? And then he'll say, oh, I have this idea. And so that's really great too, when you can have your amigo in some other area that looks at something a little bit differently. And it's true when you're interdisciplinary, like engineering and medicine, or even when you're interdisciplinary between two specialties in medicine. And you guys have to fight. And I don't mean it in a like a negative way, but you do have to battle against people putting things into a silo, right? And the only way to fight that silo, or the entropy, the trend toward single particles floating away from each other, is to put energy into the system to get those particles kind of a little bit more closely together, so that they start popping like a friggin' Jiffy Pop. And that's when things start really happening. Like, that's when you get a guy like Bijan Najafi hanging around with you. Then it's like a big old Jiffy Pop popcorn thing. Do you guys even know what Jiffy Pop is? Do you still have Jiffy Pop? No, you got to freaking Google Jiffy Pop and you'll understand what I'm saying. You put it on the stove and you heat it up.
I think that went by the way of the One Piece.
Oh, you got to look up Jiffy Pop.
Key thing.
Jiffy Pop popcorn. You'll know what I'm saying in a minute. You guys are going to want to get one of those because it's so freaking retro. If you guys have any LPs at home or vinyl, get a Jiffy Pop popcorn thing.
Anybody else have any questions for these guys? We got two of the best academicians with diabetes medicine in the world, really, and it's such a thrill to have them both here on this on this virtual screen.
Oh, thank you. It's really fun.
Yeah, I've gotten to know you a little bit better. I've known David, and David is always talking about you, Bijan. Do you have any funny stories regarding your collaboration over the years that you can share with us, since we're getting to the final minutes?
Wow, gosh.
There's got to be one.
Maybe David, you can.
David, you
I mean,
gotta have something.
Having interaction with David, spending time with David all the time was fun. So I don't know.
I'm sure
I should say.
Well,
David, you got-
I
David, you
mean,
got
look,
something.
I used to years ago, I still have it actually. It's kind of parked outside of my place, but I'm an inveterate. I'm a super early adopter of gadgets, and my definition of a gadget is very broad. But I did have a, because I was going back and forth to the operating room a lot from my office in Chicago, and I wanted to find out a way that I could do it, because walking was great, but it would take me 30, 40 minutes to do it each time. So I was thinking of all these different things, like a go-kart, or like or even you couldn't drive, and a bike was not going to work really well because you couldn't really take it inside, and then the snow. So I ended up getting a Segway. And it's a long story, but I had this discussion with Dean Kamen at the time, who had invented the Segway. But and I don't know, you guys know what these geek Segway things are, but I know that Bijan used to videotape me on the Segway, and somehow that ended up somewhere on YouTube at the time. But and I don't think you ever actually ultimately got yourself a Segway, did you, Bijan?
No, but actually I tried when I went to Budapest. Actually,
I remember you telling me that. Yeah, you were like going over the chain bridge in Budapest, going back and like this on the thing. I do recall this now. Yes, there you go. Yeah, good on you, man. Well, if you want mine, it's kind of bricked up next to my my house now. It's like some people have like they're like a pickup truck on bricks, like in front of their house. I have like a Segway.
I do have before we depart, I do have one thing that I wanted to ask both of you. How do you guys control something that is implemented, such as a cast? What is your placebo? Or let's say I wanted to control my splint, and then I'm comparing it to somebody that is using nothing, but and so that's a control. But let's say that it's known that you're not wearing something. So what's the best way to deal with that circumstance where it's known that you're not dealing with a something that's designed to help you? And then I have one quick follow-up question to that, but I'll let you does that make sense, that question?
I think the
idea of placebo when you're wearing something.
So typically I would say that's a great question. Even when it's a terrible question, and that's a great question. I'm joking. But listen. So I think what you're saying is like, how can I have a good quality control arm when if I believe that control is not helping the patient, and how can I do that? And typically what you can do is we all have our biases going into things. So you have to put your even though you can't, put your biases at the door, and you can say, well, are people doing this as part of a standard of care to treat problem X or Y? And if that's the case, then that can certainly be your control. And then your active arm, whatever that active arm is, could be something more fancy, like the thing that you want to do. Does that make sense?
Yep.
There we
How
go.
much do you feel that financial incentive for the people getting paid $30 to come to the clinic, and their desire to be well liked, and I want to help these doctors, therefore, even if I have the sham, I'm going to say I got better? How much do you think that exists, Bijan and David?
That's a good question. I don't think that that really, first of all, the amount that we give most of our patients to come in doesn't even cover a freaking bus fare. So I don't think that. I think if there was a whole lot of, I think that if there were, magnitude probably matters. If there's some massive amount of money, that would probably affect their assessment of things. But when it's just, gas money, but it's not. I don't think that's probably
It's not that relevant.
No, probably not.
Yeah.
Of course, what you mentioned is very difficult. That is become of designing of clinical trial, and one of the big challenge is defining control group. Sometimes there is also ethical issue. For instance, if somebody has wound, you cannot give an offloading that doesn't offload that wound. This is unethical. If you look at earlier study of offloading, we did the test on healthy subject who doesn't have wound, or diabetes patient who doesn't have wound, and we compare that compared to regular shoes. If the patient walked with regular shoes and then with offloading, what is the percentage of the pressure reduction? And that was the earlier study that we have done. But for wound healing, for instance, for this large grant that David explaining earlier, the way that we designed the study to be a fair comparison is to giving two arms the same offloading, but for one arm we added this gamification or this auto reminder remote patient monitoring component, and the other arm, no, it's just offloading. So both patients, they get the same treatment, but one, there is something extra, and then we can validate that whether there is something extra that we provide, it can improve what we call it as for primary outcome, that is wound healing. Because ultimately, the job of offloading is help that wound heal faster. And that's the way that we compare between two arms to say that, hey, this can significantly improve, for example, the caring for wound healing.
How important is this idea of paracrine signaling, this new idea of exosomes? First, we had placenta, Wharton's jelly, PRP, other things to help with wound healing, and my particular interest with sports medicine, because I injected my own Achilles with placenta tissue, and it did seem to help me on an anecdotal basis. But what is this, in your opinion? And I know there's still not good RCT data on it, but this idea of paracrine signaling with exosomes, and as yet another new biosphere that's going to be examined in the future and utilized, from what you can read in the tea leaves.
Yeah, well, I'll speak for tissue repair and wound healing. And look, when we treat these wounds, they're really it's a hostile environment. There's just this kind of gamish, if you will. That's a little Yiddish for you there, Najafi. But it's really just this kind of broth of inflammatory chemokines and cytokines, and so controlling that and manipulating it is super complicated, and various methods you were mentioning, treating yourself, with one of these injections of a chorion or amnion based product or a placental based product. These things probably have effects, they're immune modulating effects. And what you may be talking about as well is also being able to modulate the way that various cells behave. In fact, they can completely change cell kind of personalities. Like, for instance, a macrophage or a macrophage, if you want to be fancy, you might say macrophage. Like I'm trying to be fancy, right? I would also say capillary and umbilicus for an extra $5. But the bottom line is the macrophage is often as an M1 phenotype, and you can fundamentally change it into an M2, more of a kinder, gentler, kind of more collaborative phenotype versus a kind of an angry, just going in and eating everything up kind of phenotype. That is one very, very good example of trying to change this hostile environment, whether it's a paracrine or an autocrine or an endocrine system, or just locally into something that's a little more kinder and gentler. How's that for a weird soliloquy?
It's a good complete answer. So when young doctors are coming out and they get a fancy, let's say not lobster anymore, because that's usually not within the $20 that are allowed to spend, but let's say a decent steak, maybe a porterhouse.
By the way, there's a great lobster truck that's like right down the block from us. It's just really good, and you can get actually a pretty good lot, kind of for not that much, maybe. But anyway, keep going.
So
you can tell I'm hypo.
Yep. No. And we're going to wrap it in 2 seconds. What would your advice be as to separate industry from real science, when and some of the cues that they should look for into understanding, is this garbage, or is this the real deal?
Well, I think that there are a lot of studies that are funded by industry. I've participated in many, and I do participate in many, and I'm a principal investigator on many. Probably 30%, 40% of our funding is industry. About 70% is federal, maybe a little more. But I think that it takes both to make the world go round. You can't meaningfully do a lot of discovery without a partner with industry. But when you do that, what you have to understand is that various different companies and industry has a motive that might be different from your motive as a principal investigator, that might be different from your patient's motive, or different from health systems or health ministries motive. And I think everyone has to put their cards on the table and know where their biases are, and disclose that, and kind of move forward. And when you do that, that's when you start to get to the truth. I think a lot of the time, the truth is that a lot of technologies can be very, very helpful for people, but there are tons of things that don't ever see the light of day because maybe industry has a negative study. And so publishing negative studies and negative work is really, really important too. And I think doing that is one great way for industry to gain its credibility back. But if they lose it in other ways. So I think it's essential, but it's also essential that it improves.
Well, I don't want to put you into any more of a hypoglycemic state, David. And does anybody have any last questions for these guys, these docs tonight? Well, listen, I'm going to let you guys give the last word if you like. But what I do want to do is thank you for your generous time here tonight with sharing your views. I got to know Bijan a little bit better, and Bijan is actually taking time away, and he had to kind of sort of compress his spending time with for his son's birthday. So I really appreciate that, and happy birthday to your son. How old did he turn, Bijan?
11.
Oh, that's wonderful. That's wonderful.
I can't believe he's 11 already. Dude. That's
awesome. So thank you again. I think this is great. And GW is going to put this, and we'll send the YouTube to your respective programs so that you can have that if you want to archive it. Because I think this is ends up being a great, very stimulating, provocative talk for people to listen to.
That's for sure. By the way, at GW, I didn't realize this was going on to GW. There are so many great folks at the medical school there too. And on our end, your chief of surgery is Tony Sadawi, who's just such a great guy. He's a vascular surgeon and a wonderful mentor as well. I didn't even realize that. You guys go send him our regards.
They formed a club and really sort of alpha chaptered this idea that they would try to collaborate with local physicians like myself to provide some educational programming. And I think they're going to have the Surgeon General come over to speak at one of their meetings. They got a grant. So for undergrads, I think this little group of folks is amazing, these students.
Oh, that's really awesome. Yeah, you can definitely do that. And look, one of my one of my friends is that I worked with and work with now is former Surgeon General as well, and I bet he can get on too. And that's Rich Carmona.
That's
as well.
exactly.
So, you're talking about Rich Carmona?
Yeah, we were paying him $15K to come speak with us.
What the what? Well, that's
Yeah.
that's great. But that's well, listen, send my regards to Richard Carmona. He's you can ask him. I'm sure he'll have great stories to tell you.
Yeah.
But I think he'll be full of great wisdom. That's for sure.
Yes, I know. I have the chance to collaborate with the team.
Sure you did.
Yes.
Wow. And thank you.
Yeah.
Thank you so much for everyone for coming today. Like,
No, not at all.
making this happen. Like, we had I believe almost 40 people in attendance. This is like in our social media groups, like this is one of the most talked about, and people liked our images, the posts. So
you guys are the first or second
We
on campus.
appreciate it very much. Not at all. And when you talk to Rich Carmona, you can ask him about when he was with me at my house barbecuing with the ambassador to Cuba. Ask him that. Ask him to tell you that story. And that's Jorge Cabañas, actually, who's now no longer the ambassador to Cuba. That was about a growth factor, actually. Interestingly, you guys will see that. Yeah, the very first ambassador to Cuba.
that's so cool.
Yeah, that'll be. Yeah, were you there, Bijan? That was after you left, wasn't it?
I missed that actually. I wasn't there.
That was after you left Tucson. Yeah, there you are.
Maybe it would be cool if you guys wanted to come to the health summit and have that conversation there. I think that'd be a really.
Oh yeah, well, just ping me when that happens. I'll see if I can pop on.
Okay, that sounds great. Thank you so much.
For sure. All right, you guys. Listen, take care and be well. This was a lot of fun.
Thank you, guys.
Thank you
Very
very
much.
much. Thank you all.
Okay.
Bye.
Good night, everybody.
Good night.
Good night. All right. Well, hey, when Adam, when you get this wrapped up, please send it to me, and then